Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing to it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. In the last lesson, we discussed a common breast condition, aberrations of normal development and involution, or ND. Today we shall talk about another important breast affliction, that is breast cancer. Breast cancer is the leading cause of cancer-related deaths among women. Worldwide, the incidence of breast cancer is second only to lung cancer. The most common type of breast cancer is invasive ductal carcinoma with or without ductal carcinoma in situ, accounting for 70% of breast cancers. Invasive lobular carcinoma is the second most common type. 20% of breast cancers detected by mammography screening prove to be ductal carcinoma in situ. Pure ductal carcinoma in situ does not cause lymph node metastasis. Most breast cancer cases are sporadic. Only a quarter to a third are familial. Paget's disease of the nipple is a superficial manifestation of an underlying breast carcinoma. The etiology of breast cancer is attributed to a complex interaction between various modifiable and non-modifiable factors. This etiology is determined by environmental, nutritional, hormonal and genetic elements that contribute to the development of this disease. Risk factors include female gender, increasing age, a strong family history of breast cancer, personal history of breast cancer, histologic factors, germline mutations, postmenopausal obesity, fatty food, tall stature, smoking, high alcohol consumption, nulliparity, absence of breastfeeding, late first pregnancy, especially if associated with early menarche and late menopause, tobacco smoking, exogenous hormone therapy, physical inactivity, and high dose radiation therapy to chest wall at young age. Age is the most important risk factor for breast cancer development. Breast cancer is extremely rare in women under 20 years. Incidence increases rapidly after the age of 30. Female gender is the second most important breast cancer risk factor because approximately 99% of breast cancers occur in women and only 0.5 to 1% of breast cancers occur in men. First degree relatives such as mothers, sisters and daughters of patients with breast cancer have a twofold to threefold excess risk for getting breast cancer. A history of cancer is one breast increases the likelihood of a second primary cancer in the contralateral breast. Histologic abnormalities diagnosed by breast biopsy, such as lobular carcinoma in situ and proliferative changes with atypia, constitute another important category of breast cancer risk factors. Genetic factors such as mutations in cancer susceptibility genes are estimated to be responsible for 5 to 10% of all breast cancer cases. Most notable high-risk genes associated with familial breast cancer are BRCA1, BRCA2 and TP53. Reproductive factors that increase a woman's lifetime estrogen exposure are associated with an increased risk of her developing breast cancer, whereas reducing this exposure is protective. Therefore, factors that increase the number of menstrual cycles, such as menarche before 12 years of age, nulliparity, first live childbirth after 30 years, and menopause after 55 years, are associated with increased risk. Moderate exercise and a long lactation period are factors that decrease the total number of menstrual cycles are protective. Long-term exposure to the combined preparations of hormone replacement therapy and oral contraceptive pill significantly increases the risk of developing breast cancer. The proliferation of breast epithelium associated with a full-term pregnancy is also protective. So, older age at first live birth is associated with an increased risk of breast cancer. Postmenopausal obesity increases the breast cancer risk because in postmenopausal women there is conversion of androstenedione to estrone and estradiol by adipose tissue with a long-term increase in estrogen exposure. Also, long-term consumption of foods with a high fat content contributes to an increased risk of breast cancer by increasing serum estrogen levels. Mantle irradiation therapy in young women, especially before the age of 30, for Hodgkin's lymphoma and other cancers, carries a 2 to 4-fold greater breast cancer risk. Breast cancer risk increases as the amount of alcohol a woman consumes because alcohol intake is known to increase serum levels of estradiol. Breast cancers arise from the epithelium of duct system. Hence, almost all breast malignancies are adenocarcinomas. The disease may be entirely in pre-invasive in situ stage. It is usually described as 3 grades: well differentiated, moderately differentiated, and poorly differentiated. A numerical TNM grading system based on nuclear pleomorphism, tubule formation, and mitotic rate is also used. TNM grade 3 cancers roughly represent the poorly differentiated group. Histological descriptions are also in use, such as ductal carcinoma and lobular carcinoma. In the present day era of molecular markers, there is a change in the way that breast cancers are classified. Gene array analysis of breast cancers has described 5 major molecular subtypes: luminal A, luminal B, triple negative, HER2 receptor positive, and miscellaneous group, each with distinctive biologic and clinical features. The luminal A is the most common molecular subtype of breast cancer. It is characterized by the presence of estrogen and progesterone receptors and the absence of HER2. In other words, luminal A breast cancers are receptor positive and HER2 negative. Luminal A breast cancer cells are similar to normal cells, grow slowly, and have a good prognosis. The cancer is called pre-invasive or in situ carcinoma if it has not breached the epithelial basement membrane. Here, cancer cells remain confined within the ducts and lobules. These cancers have no capacity to metastasize because these have no access to blood vessels and lymphatics. The in situ carcinoma is usually asymptomatic and is diagnosed in breast biopsy specimens, but this diagnosis is becoming increasingly common because of the wide use of mammographic screening. The in situ carcinoma may be ductal or lobular. Ductal carcinoma is the most common variant. The lobular carcinoma in situ is often multifocal and bilateral. Both DCIS and LCIS are risk factors for development of invasive cancer later in at least 20% of patients. The best treatment for in situ breast carcinoma is a subject of debate. Colloid or mucinous carcinoma, medullary carcinoma, and tubular carcinoma are rarer histological variants and usually carry a better prognosis. The medullary carcinoma is characterized by solid sheets of large cells, often associated with a marked lymphocytic reaction. A staining for estrogen and progesterone receptors is now routine in breast cancer management because their positivity indicates the use of adjuvant hormonal therapy with tamoxifen or an aromatase inhibitor. A staining for HER2 or CRB2 is also done, and positive cases are treated with the monoclonal antibody trastuzumab. Ductal carcinoma in situ or DCIS is the commonest cancer found in female breast. but in males it accounts for 5% cases of breast cancer. In DCIS, there is a clonal proliferation of epithelial cells limited to ducts by the basement membrane. DCIS carries a high risk for propagation to an invasive cancer. The risk for invasive breast cancer is increased nearly fivefold in women with DCIS. DCIS is an anatomic precursor of invasive ductal carcinoma because the invasive cancers develop in the same breast and usually in the same quadrant in which the DCIS was originally detected. Histologically, DCIS is characterized by a proliferation of the minor duct epithelium. The cancer forms papillary growths within the duct lumen. There is difficulty in distinguishing early DCIS from benign hyperplasia because in earlier stages the cancer cells do not show pleomorphism, mitosis, or atypia. Later on, the intraluminal papillary growths coalesce and fill the duct lumina and show hyperchromasia, pleomorphism, and loss of polarity. Eventually, cancer cells with frequent mitotic figures obliterate the lumina and distend the ducts with solid growth patterns. Now, these cells outstrip their blood supply and become necrotic with a comedo growth pattern. Calcium deposition occurs in the areas of necrosis, which is commonly seen on mammography as microcalcifications. DCIS is almost always detected by mammography. The DCIS is now frequently classified using one news system based on the patient's age, type of DCIS, presence of microcalcifications, extent of resection margin, and size of the disease. Patients with a high grade are recommended complete excision followed by radiotherapy, whereas those with a low grade need complete excision and no further treatment. Lobular carcinoma in situ or LCIS is responsible for up to 15% of invasive breast cancer cases. It originates from the lobules of terminal ducts and affects only the female breast. LCIS is observed predominantly in younger premenopausal women. It is bilateral in 20% to 40% of cases when compared with DCIS. There are two subtypes of lobular cancer, the classical type and the pleomorphic type. The classical type carries a better prognosis. LCIS is typically an incidental finding at biopsy for another condition. It does not manifest as a palpable mass or suspicious microcalcifications on mammography. Mucin positive signet ring cells are commonly present. LCIS is almost always receptor positive and HER2 negative. Lobular carcinoma is E-Catherine antibody positive on immunohistochemical analysis. This fact helps differentiate lobular carcinoma from other types in doubtful cases. The invasive lobular carcinoma is commonly multifocal and bilateral. For most patients with LCIS, a conservative approach is favored. Treatment choices include close observation, chemoprevention with tamoxifen, or bilateral mastectomy. For elective surgery, bilateral total nipple skin sparing mastectomy is the procedure of choice. LCIS predisposes to subsequent carcinoma later, and the risk is lifelong and equal for both breasts. Inflammatory breast carcinoma is a rare and highly aggressive undifferentiated cancer. It presents as a warm, painful, and swollen breast with cutaneous edema and may mimic a breast abscess. It results from blockage of the subdermal lymphatics with carcinoma cells. It usually involves at least one-third of the breast. Prognosis is poor and 3-year survival rate is only 3 to 10%. As the tumor increases in size, it invades other portions of the breast and tends to involve the skin, pectoral muscles, and even the chest wall in late cases. Systemic spread occurs through lymphatics and bloodstream. The axillary and the internal mammary lymph nodes are involved first. Supraclavicular nodes and any contralateral lymph nodes are affected in advanced disease. A skeletal metastasis occurs through bloodstream to lumbar vertebrae, femur, thoracic vertebrae, ribs, and the skull in order of decreasing frequency. Breast cancer produces osteolytic metastasis. Solid organs receiving metastasis from breast carcinoma are the liver, lungs, brain, adrenal glands, and ovaries. Recognition of circulating tumor DNA in peripheral blood samples has shown prognostic significance and can be used to monitor treatment response. Most breast cancer patients are asymptomatic, and lesions are discovered during routine breast examination or a screening mammography, or in majority of times the patient notices a palpable lump herself. Carcinoma of the breast occurs usually in women above 40 years of age, though rarely it may occur earlier, so age should not be a criterion to exclude the diagnosis of breast carcinoma. It is important to know if the woman is currently taking oral contraceptives or postmenopausal hormone therapy and whether she has taken these in the past. Ask about treatment for infertility and prenatal exposure to diethylacetylbestrode. Finally, a personal history of cancer of the contralateral breast or other sites is important. Ovarian and endometrial carcinoma are each associated with an increased risk of breast cancer through common genetic predisposition. History of radiation treatment to the head and neck or mantle irradiation for Hodgkin's disease should be explored. The commonest mode of presentation of breast cancer is a painless lump. Pain is more common with benign diseases, but may also be seen with breast cancer in 5% cases. Remember that all neoplasms of the breast, either benign or malignant, including carcinoma, are painless to start with. A lump which is painless and incidentally felt may be a breast carcinoma. More advanced disease may present with symptoms such as recent retraction of nipple, pudiorange, eczematous ulceration of skin, axillary lump, or signs of distant metastasis. Inflammatory breast cancer may have clinical features similar to a breast abscess. A thorough physical examination is essential for the clinical assessment of a suspected breast cancer patient. Carcinoma can occur anywhere in the breast, including the axillary tail, but it is commonly found in the upper and outer quadrants. So, all four quadrants should be palpated. Both breasts must be examined in sitting, standing, and supine positions, with the arm abducted, extended, and externally rotated. Overlying the skin changes, regional lymph node enlargement, nipple discharge, particularly if blood stained, brani arm edema, pudiorange, and local skin ulceration should be noted. The clinician should maintain a high index of suspicion for symptoms of metastatic spread to bone, lung, liver, and brain, such as bone pain, symptoms of hypercalcemia, breathing difficulties, abdominal distension, jaundice, localizing neurological signs, altered cognitive function, and headache. Thank you so much for watching. Please subscribe and stay tuned for more educational videos.